So necrosis types, 6 types of necrosis. They are coagulative, liquefactive, caseous, fibrinoid and fat. Coagulative, the most important thing is neutrophils will have a bent nuclei. I'll zoom this image. Can I call this a bent nuclei? Obviously I can, right? A bent nuclei. It's a nuclei. I'm not calling it lobes exactly. It's just a bent nuclei. If the nucleus bent, it's a neutrophil. Pedigree analysis. I'm just jumping topics, just touching the most important thing required for you just before the day of the exam. Hey guys, so welcome back. I hope you are enjoying your day, the weekend on a Sunday evening. I know it's difficult to start with discussion again. So I'll go through a very brief discussion of what to look for pathology when you have a day or two before the exam, right? It's going to be a very short and a crisp discussion. I'll run through the slides. And if you're online, let's have an interactive session. Otherwise, I'll just note down the points. Maybe the day before the exam, if you want to plug in and if you want to recap the entire pathology in a couple of hours, this will be the best source for it, right? So let's start. It's going to be in one short series. I'll touch base on all the important aspects which has been covered in pathology till now in the last 5 to 6 years of PYQs, including the topics somewhat around that, fine. And immunology, I'm not taking it here because I'm sure it will be covered in microbiology, so I'm not involving much of immunology here. I'll go through your general pathology, a little bit of hemat, and a little bit of favorite topics from histopath with respect to the NEET PG exam, right? So if that's ready, let's go on. Let's start the discussion here. So first thing is about cell adaptation, right? So there are 4 types of cell adaptation. You know that by default. There are few pointers which has been repeated in cell adaptation. One is the mechanism of action. In hyperplasia, you know for a fact the mechanism of action in hyperplasia is increased proliferation with the help of stem cells, right? I'll just make it smaller, okay? With the help of stem cells, that's increased cell division is the mechanism for hyperplasia. For hypertrophy, it's going to be increase in the mRNA or increase in the protein content, right? So more the protein it is, you're going to have more amount of the cytoplasm. It becomes bigger, it's hypertrophy. Metaplasia, you're going to have a reprogramming of stem cells. You'll reprogram the stem cells, which means, meta means change, right? So primarily the cell which produces squamous epithelium now has to produce columnar epithelium. So I'm going to reprogram stem cell. Atrophy, actually there are 2 things, right? So that makes the second answer also relatable. One is autophagy. So based on autophagy, self-eating mechanism, there's smaller shrunken cell size and also a little bit of apoptosis. Since there's a little bit of apoptosis, that's one reason that atrophy can be an irreversible change. It can be, and it's not always, it can be an irreversible change because there's also apoptosis involved. For example, thymic atrophy. You are an adult, I am an adult, and I don't have a thymus. It's atrophied. It will never come back to normal life. At the same time, you have an atrophy due to protein energy malnutrition. That's when I treat it, it'll come back to normal, right? That's reversible as well as irreversible. Rest, everything are reversible change. Be it hyperplasia, hypertrophy, metaplasia, it'll definitely come back to normal, right? So which all this will definitely cause cancer. Whenever a stem cell is involved, there's also a stem cell, there's definitely an increase in risk of cancer. By default, there's an increased risk of cancer, right? Hypertrophy, there's no increase in risk of cancer. This has been repeated, whenever muscle hypertrophy, cardiac hypertrophy, you won't have an increased risk of cancer at all, right? But on the other hand, atrophy, not every atrophy, only one atrophy, which is endometrial atrophy. Endometrial atrophy by default can have an increased risk of cancer, others will not have, right? I'm not going too much into examples. You guys know hyperplasia. The best example for is endometrium. Be it physiological or pathological, we'll have hyperplasia. Hypertrophy, it's muscle. Skeletal muscle in bodybuilding and cardiac muscle due to hypertension or other causes. Metaplasia, I want you to stress on this. Squamous metaplasia, which happens in the respiratory epithelium, is the most common metaplasia. Please don't write Barrett's esophagus because I'm sure everyone must have at least revised Barrett's 10 times till now, right? You'll do it more as well. Barrett's esophagus is there in your mind, but that is not the most common metaplasia. Squamous metaplasia due to smoking is most common because smoking is any day more common than GERD, right? That's why it is. Atrophy, multiple examples I gave in the discussion. All of them are examples of atrophy. You can have a denervation atrophy. You can have a protein energy malnutrition induced, ischemia induced, right? Many things. Disuse atrophy. You don't use an organ after fracture, plaster of Paris cast. The hand becomes smaller. Or in hemiplegia, hand becomes smaller. I don't use it, right? That's how it is, fine. Okay. And also the embryological form of atrophy also exists, fine. Only one point I want to add in atrophy. In microscopic structure atrophy, you will have lipofuscin deposits. When there's lipofuscin deposits, by default, that will happen in microscopic features of atrophy, fine. So So let's go to the next slide. So I'll have like 30-40 slides, the high yield pointers for you to revise in the next like 1.5 hours before the exam, right? So necrosis types, 6 types of necrosis. Coagulative, liquefactive, caseous, fibrinoid, and fat. Coagulative, the most important thing is maintained architecture. When the architecture is maintained, it's not distorted in microscopy, it's coagulative necrosis. Every solid organ infarct, and I'm sure 100% know, except brain infarct. So brain infarct will come under liquefactive necrosis. Abscess cavity and wet gangrene also comes under liquefactive necrosis. Dry gangrene is actually an infarct. So it automatically comes under coagulative necrosis only, right? If it's caseous actually is a gross terminology, it's not a microscopic terminology. Grossly, if you have a cheesy appearance, you call it in caseous necrosis. Caseous necrosis, one thing is tuberculosis. Apart from that, histoplasma can have caseous necrosis. 𝐒𝐿 𝐷 also can have caseous necrosis, right? Just running through because we already know all these stuffs, right? Fibrinoid, oid means like, fibrin-like necrosis, which happens in vessel wall. Be it a vasculitis, be it a trauma, be it anything regarding vessel wall or heart. One thing you might miss is your Aschoff bodies. Aschoff bodies, in case of your rheumatoid arthritis, can have fibrinoid necrosis. This is common in exam, and I'm sure you must know that. Fibrinoid, it's fibrin-like necrosis. One extra point, especially if you're preparing for NACD, fibrinoid necrosis is definitely PAS positive. Okay, because fibrin is PAS positive, like that becomes fibrinoid necrosis, it has to be PAS positive, right? Fat necrosis, anything rich in fat can have it, right? Any structure rich in fat. 2 different subtypes. You can have omentum necrosis in case of an acute pancreatitis. So you have the lipase coming out of the pancreas, destroying the omentum, and trauma induced. You can have trauma induced breast parenchyma, you can have trauma induced gluteal region, or any structure rich in fat. When there's a trauma, you'll have traumatic fat necrosis as well, right? So these are different types of necrosis to revise, right? I'm not going to apoptosis because quite like 3-4 years there's not been much question on apoptosis. Just to recap, it's a programmed cell death. You have 2 pathways, the mitochondrial derived pathway and the cell membrane derived pathway. BCL2, BCLX, BCMCL1, right? Whichever has L has a longer life, it's anti-apoptotic. Backs and back is pro-apoptotic, right? Once the DNA error or a viral replication comes, backs and back will kind of become more, and BCL2 will kind of become less, which triggers the caspase. Apoptosis and caspase dependent cell death. That's all. That's the only thing which might be required. Necroptosis starts as apoptosis in the extrinsic pathway or the cell membrane mediated pathway in viruses or in steatohepatitis or in IBD. The apoptosis somehow stopped. So it kind of triggers MLKL. MLKL, this can come in an exam. So in case of necroptosis, there is a protein called an MLKL. So this MLKL kind of puts pores in the cell membrane, so ends as a necrosis. That's what happens in necroptosis. Starts as apoptosis, ends up in necroptosis. That's necrosis, classical of necroptosis, fine. Pyroptosis, it's inflammation or fever induced, right? So the only thing which I want you to remember in pyroptosis, it's mediated by interleukin 1 and the inflammasome. Anything which can trigger inflammasome pathway will end up in having fever and apoptosis, which is pyroptosis. Pyroptosis also caspase dependent only. Necroptosis caspase independent, and apoptosis obviously is caspase dependent, right? So there's a few things which I want to recollect in the first chapter. Add something called Daskadam in the PW Method YouTube channel. When you have time, go there. I've discussed in detail about the special stains, the microscopic accumulations, be it iron accumulation, be it a copper accumulation, be it calcium. That will come handy for sure, right? So this 1.5 hours, and that will sum up entire thing required for pathology. That's more than enough. At the last minute, like 3-4 hours of pathology, more than enough to quickly recap whatever is required for us, right? So let's go to inflammation. So inflammation, I have 2 things, right? Acute and chronic inflammation. You've been reading that from your first year of MBBS. Hallmark of acute inflammation is nothing but its increase in your vascular permeability. More and more vascular permeability you have. Edema, vascular permeability is the hallmark of acute inflammation, right? Chronic inflammation, we know. There's a famous guy, right? I love this one. TDHF. Tissue destruction, healing by fibrosis. Whatever chronic inflammatory state happens in the body, it will destroy that tissue, it will heal by fibrosis. Classical example is tuberculosis. Fibrocavity lesion, which happens on an X-ray. That's how it happens, right? So there are few inflammatory cells. This can come handy if you're stuck in an image. I don't know what is an image. I have an image of glomerulus, but I'm not able to understand what it's about. Just go back to this point. It will help to easily solve it. I'll tell you how to do it, right? Neutrophils will have a bent nuclei. I'll zoom this image. Can I call this a bent nuclei? Obviously I can, right? A bent nuclei? It's a nuclei. I'm not calling it lobes exactly. It's just a bent nuclei. If the nuclei is bent, it's a neutrophil. If it's pink color cytoplasm, it's an eosinophil. Anything allergic, anything parasitic, think about eosinophil, right? Small round blue cells, right? Small round and blue cells, they are lymphocytes. Anything viral related, anything autoimmune, think of lymphocytes. It's viral or autoimmune etiology. Lymphoplasmacytes, right? And you have giant cells. Again, chronic inflammation, think of this. And remember, if it's only a normal macrophage will be clear in appearance. Actually, macrophage is the cell of chronic inflammation as well. Any chronic inflammation, you'll see macrophages, you might not see lymphocytes, right? So these are just pointers to help. Like, how will this help in me to solve a question, right? Ultimately, we have to solve a question, that's all. Like I gave an example, I am not able to understand what happens in the glomerulus. But if I can see a neutrophil in a glomeruli, I can identify a neutrophil because the bent nuclei. Same thing will look in glomerulus also. So can I say it's an acute inflammation in glomeruli? Acute bacterial inflammation? Obviously, right? PSGN, that's all. That's it. If you see lots of eosinophil in the esophagus, eosinophilic esophagitis, allergy mediated, bronchus, asthma, bladder, interstitial nephritis, drug induced, blood vessel, Church-Strauss syndrome, vasculitis with eosinophilia, right? One cell can help me to extrapolate and identify different things because the same thing. Lymphocytes. Lymphocytes in thyroid, hypothyroidism, Hashimoto's thyroiditis, autoimmune. Lymphocytes in the lung, viral pneumonia, mycoplasma pneumonia, atypical pneumonia, that's all. So this helps me. Like lymphocytes in a pancreas, I might think of an autoimmune pancreatitis, right? So this helps me to diagnose, or at least sometimes to rule out the other options, right? So you have chronic inflammation, granuloma, you know what to look for, and we have discussed granuloma multiple times before, right? So these are just clues for me, pointers for me to identify what happens if I'm stuck, right? That's one, right? Next, to go to pedigree analysis. I'm just jumping topics, just touching the most important thing required for you just before the day of the exam. Pedigree might come. Pedigree comes like alternate years, at least in one exam it comes, right? So hopefully we can expect pedigree in this exam. If a pedigree comes, don't worry, 10 seconds is the rule. If you cannot identify the pedigree in 10 seconds, the pedigree is wrong, right? That's all. Follow the same rules. These rules are by Gregor Mendel, not by me, right? The first and the foremost thing, never change the order of rules. The first and foremost thing is rule out mitochondrial inheritance. Second rule, look for it. If all the generations are affected, every generation is affected in this pedigree. If the answer to this is no, not affected, right? Then I'm thinking of a recessive disorder. If I'm thinking of a recessive disorder, and if only men are affected, I think of an X-linked recessive disorder. If both men and women are affected, I think of an autosomal recessive disorder, right? That's how I'm going to differentiate your recessive inheritance in the form of a pedigree analysis, right? Both involved and only men and women involved. And the starting point is all generations are not affected, right? That's the second rule for me, to rule out or to identify all the recessive inheritance, right? When you go to third, the third thing is very simple. One more flowchart, that's all. All generation affected. Answer is yes. Dominant disorder, right? Then I have to ask two more questions, that's all. It's not as simple as my recessive, just two more questions. Is dad to son affected? Simple example, let's assume I'm giving birth to a son. To give birth to a son, I have to give my Y chromosome. I won't give my X chromosome, because if I give the X chromosome, mother obviously will give only X chromosome. It becomes a daughter, right? So dad to son transmission will never ever happen if it's an X-linked recessive disorder, because there's no chance I can transfer my X chromosome and the kid becomes a boy. It has to become a girl, right? That's the first thing. If the answer is yes, okay, the dad has transmitted the disease to the son, it has to be by default autosomal dominant. So here it's a query. To answer this query, I ask the second question. Same example, I have a kid who's a daughter and my X chromosome is having a mutation and dominant mutation, which means one allele is enough to cause the disease. I give the X chromosome to zygote. By default, the zygote will become a daughter, and by default, it will be the mutated X. So how much of a daughter I produce, or the zygote of female I produce, that will always carry the mutation, that will always have the disease, right? So if the answer to all the daughters being affected, it should be 100%. If 100% of the daughters born to an affected dad is there in the pedigree, the answer is yes means X-linked dominant, no means autosomal dominant, right? Take a screenshot of these two things, have in your gallery, listen to the day before the exam, or use the notes, listen to read the day before the exam. That's very, very important, because these two are enough for you to solve any pedigree which comes to you, right? Let's see, let's try out. All generation affected or not? No. First generation not affected, right? Perfect. So dominant or recessive? Okay, recessive. Next question is, only men or both men and women? Answer is both men and women. So it is, right, both men and women. So it is an autosomal recessive inheritance. It should take less than 10 seconds by default, right? Let's try one more pedigree. All generation affected or not? No. Recessive. Only men or both men and women? Both men and women. You'll write perfect. Autosomal recessive. If you're doing this, write a big no here. Big no. Because you skipped the first rule. What's the first rule? First rule is always this. So any pedigree which comes from today to you, you have to rule out mitochondrial inheritance by default. That's a first rule by default, right? So once you rule out mitochondrial inheritance, that's the first rule, because mitochondrial is not Mendelian pattern of inheritance. That's why here, mom affected, all kids affected. Dad affected, none affected. Mom affected, 100% affected. So this is mitochondrial. But if you miss the first rule, you might go into the flow charts and you might wrongly write this as autosomal recessive inheritance, right? The first rule always stays the same. It's mitochondrial. Then go to the flow charts. Please don't skip the first rule. You might lose your 4 precious marks, right? Okay. Now just few one-liners with regards to genetics, because there's one more place where questions can come in. Genetics is your relative risk. Mother is a dominant person. What's the chance the baby can have a disease? Or both the parents are carriers of a recessive condition. What's the chance the baby can have a disease? You know the Punnett square way back in the 12th standard. Put that and solve it. Or the flow charts. Put that and solve it. It'll easily solve the query, right? Now let's come to best modalities of diagnosis. This can be applied to systemic pathology, hematology, wherever it's asked. If the genetic mutation or translocation is known, for example, CML, I know what I'm going to look for. 922, Philadelphia. In that case, fish is undoubtedly better than karyotyping. If I don't know what's the problem, for example, there's a first trimester abortion. Can you know what's the problem? Is it trisomy 1 or trisomy 2 or 16? No, I don't know, right? So if I don't know what I'm looking for, karyotyping is better than fish, because karyotyping gives a screenshot of all the 46 chromosomes. Fish gives only what I want to look for, right? Mutation, the first line is always a PCR. If you have to quantify, like I have to say how many cells are having the mutation, go for a real-time PCR or a qPCR, right? Q is a quantitative PCR or real-time, right? Gold standard for mutation, if the question has gold standard, it's undoubtedly sequencing. PCR is not gold standard, and sequencing is the investigation of choice, right, for cystic fibrosis. Nowadays, cystic fibrosis are not diagnosed by your nasal potential difference, nor with your sweat chloride test, right? Days are gone. Maybe when I was doing my second year, that time, yes, sweat chloride was very much useful. Now you suspect cystic fibrosis clinically, prove it via sequencing, go ahead and treat and manage the patient. That's what is required for your from your genetics, just investigation of choice, right? I'm not going primarily into neoplasia here, but I want you to go to the PW recorded lectures. There is an video called as patterns of neoplasia. At least that, see it, and you have the rapid revision also. I have a couple of modules in the neoplasia chapter. Just go and have a look at that. Most of the questions which came in the recent INICET also is covered in that. That's more than enough, right? Now let's jump to hematology or an RBC disorders, right? So here in RBC disorders, I'm going to talk about template-based diagnosis, be it RBC, be it WBC, be it systemic pathology. I want you to go with the template. I'll tell you the reason and advantage of going with the template. If I go with the template, I know what all I should know, right? Even if I forget this, I know that, because this template I will revise in every disease. So I know what all the points is required, and definitely even if I forget something, you can easily recollect, okay, this is what it was, right? So it's very simple for us to understand, right? So first thing, I'm going to talk about hereditary spherocytosis. Okay, etiology, it's a genetic disease. Most common is autosomal dominant, and the most common mutation is ANKYRAN mutation. Okay, so it's obviously an intracorpuscular defect, which means the defect is in the RBC, not from outside. Inheritance is autosomal dominant, like I said. Okay, pathogenesis, because of the mutation, the RBC becomes spherical. The spherical RBC, when they go via the spleen, they'll be caught in the spleen and they'll be destroyed in the spleen, right? So it's an extravascular type of hemolysis. The hemolysis happens outside the vessel. That's your extravascular hemolysis. which is classical in case of an hereditary spherocytosis, right? History, any autosomal dominant disease will present during adult life. It will be a very mild hemolysis. The patient will have a palpable spleen. History means including examination. And one of the classical presentations of HS is they present with pigmented gallstones. That's very, very classical, right? Pigmented gallbladder calculi is the classical finding for or presentation of most of the patients with HS in real time also. Don't forget that, right? CBC finding, I'm going to see spherocytes. So CBC finding is your, elevated MCHC. This is important because the only disease where you'll have elevated mean corpuscular hemoglobin concentration. I want you guys to remember that, right? And peripheral smear, how to identify spherocyte? Easy, right? It'll be smaller, right? It'll be darker because there's an elevated MCHC, and there'll be no central pallor. Anything you look at this in peripheral smear, let's look at the image. Let's assume this is an normal RBC, fine? And look at this. This RBC is smaller than this RBC, right? Darker than the RBC, obviously. No central pallor, right? That's how you pick up spherocytes. There are plenty of spherocytes here. Look at this. Multiple things, they don't have a central pallor, right? So this is how you pick up at spherocytosis. And there's been a repeated question being asked again and again and again. See, any age group, be it a young child or an adult or a 70-year-old person, the most common cause of spherocytes is not hereditary spherocytosis, it is autoimmune hemolytic anemia. And whenever you see spherocytes in periphery, like I said, please remember the age does not matter here. Whatever age it may be it a young child or an adult or an elderly 70-80-year-old person, right? Whenever you see spherocytes in a peripheral smear, the next step to do is only one thing, which has to rule out autoimmune hemolytic anemia, which is Coombs test. There's a test called an osmotic fragility test. It's never been done in real life. To rule out autoimmune hemolytic anemia, you have to do Coombs test because that's the most common cause at any age group. By default, it's the most common cause, right? So investigation of choice for your HS, I'm talking about HS, is your EMA flow cytometry, just the investigation of choice. Eosin 5 maleimide based flow cytometry, and treatment is nothing but your simple splenectomy. You remove the spleen, that's more than enough for these patients to take care of them mostly in the life, right? So this is what we're going to see for every disease. This is a case sheet. This is the high yield, the most important point required just to swim. See, because you already know the concepts. I'm just compiling data. So if you want to just look at one PDF, like 30-40 pages the day before the exam, this will be the thing. This will be the place by default, right? Next, same thing. Etiology, it's a trigger-induced hemolysis. So it's mostly due to your reactooxin species. The disease we are talking about is G6PD deficiency. It's an enzyme deficiency, X-linked recessive inheritance, intracorpuscular defect. Pathogenesis, more amount of reactooxin species, which is going to destroy the RBC. This can cause both intravascular, intra is more important for me, and extravascular hemolysis, right? So how do I pick up? It's a trigger. The patient might have fever, the patient might have taken a drug intake, right? Or the patient might have had anything. It's like drugs like your primaquine is one of the commonest implicated drugs, and the fava beans. So this trigger will be there in hemolysis. That's the most classical thing here. CBC finding not much important except for anemia. Peripheral smear, a classical finding of the bite cells. You can see them, right? You will see spherocytes also. Okay, you'll see spherocytes, you'll see bite cells. Investigation choice, undoubtedly, it's an enzyme deficiency. Every enzyme deficiency will have enzyme analysis. That is the investigation choice you do in this patient. Treatment, it's a supportive management. Need not worry about anything. Just take care of the patient's trigger. Still fever, there'll be hemolysis. If there's very high hemolysis, maybe transfuse, wait for it. Automatically, it'll come back to normal by default. That's what you're going to do for G6PD deficiency. Again, whatever has been asked till now is there in this image. Is there in this slide? That's more than enough, right? Next. So here you can see a classical sickle cell anemia, right? Sickle cell anemia, you know, it is an autosomal recessive inheritance. The etiology, right? This is one mutation which none of you will forget. Beta globin 6-chain glutamic acid becomes valent. That's what it is, right? In the beta globin sixth position, the glutamate or glutamic acid becomes valid. Because of this, there will be a reduced solubility of hemoglobin. That is the main pathogenesis here. Because of this, the hemoglobin kind of becomes a clump. You'll have clumps of hemoglobin in the cytoplasm. This clump on deoxygenation, that's where it's more important. On deoxygenation can damage membrane. And the clump formation also happens more in deoxygenated state when it damages membrane, which converts them into sickle. And the sickle will get caught in the spleen, it can undergo lysis, or the clump itself can rupture and also can undergo lysis. The problem in sickle is not due to anemia, most likely. The problem in sickle will most always be due to vaso-occlusive crisis. Because the reversible sickle RBCs are definitely having a sticky nature. So it can affect an arteriole and can destroy. For example, dactylitis. This is the most common vaso-occlusive crisis. This is an MCQ again. Finger pain, because peripheral deoxygenated state, more clumping can cause it. Autosplenectomy, unexplained abdomen pain, acute chest syndrome, priapism, chronic leg ulcer. All these are due to a reversible sickle RBC. All of them are due to vaso-occlusive crisis. Sickle presenting as anemia is very rare. Sickle is a very, very painful disease. Imagine you're having infarct every single day in the abdomen because spleen has to destroy because of the infarct, right? It's a very, very painful disease. That's how they present. CBC, I don't have any particular finding. You have your drepanocytes. By the way, there's one more name of sickle cells. I'm writing this so that you don't get affected by this also. This also is an intracorpuscular defect. Investigation of choice, I would prefer an HPLC. If it's not there, you go for an hemoglobin electrophoresis. That also is good enough to diagnose. Treatment, this is the first disease which has been completely cured by CRISPR. The CRISPR results are out. CRISPR is a mode of a gene therapy. A person who got the CRISPR based sickle problem, which has been treated by CRISPR, they came after 4 years. They have told that the amount of vaso-occlusive crisis which has happened after CRISPR and before CRISPR is tremendously low. So it does work, and hopefully when it becomes cheaper, we can use it for multiple patients, right? These are the kind of narrowed and sickled RBCs, right? I've shown you much better images, and these are the narrowed and sickled RBCs diagnostic of your sickle cell anemia. Okay, next let's go to thalassemia. Thalassemia, I'm going to go with primarily with beta thalassemia, especially beta thal major, because that's the most severe disease. So etiology here also is a mutation. It's undoubtedly the mutation which can be due to splice site. Okay, splicing mutation can happen, or it can be complete deletion. Whatever it is, if it's beta thal, there is 0% synthesis of beta chains. So the 0% synthesis of beta chains, obviously there will be an excess of alpha chains, because I have to compensate to form a quaternary structure of hemoglobin, right? This excess alpha chain will cause clumps, and this clumps will destroy. I'm talking about beta thal major, right? Will destroy even RBC's precursors. The only reason why this anemia is very severe is it destroys the bone marrow precursors. It will not wait till the RBC comes outside. It will destroy way back, right? And this is a very classical finding. The perfect target cell. Very, very classical. Autosomal recessive inheritance, intracorpuscular defect. We talked about the pathogenesis. That's how it's going to get destroyed, right? History, beta thal major again, because minor kind of mimics your iron deficiency anemia. Major presents after 6 months, very early in life, and failure to thrive. The reason of presenting after 6 months, you know that till 6 months you'll have hemoglobin F, which is alpha 2, gamma 2, no beta, obviously it will not present, right? Failure to thrive more than after 6 months presentation is classical finding. The patient have a classical hemolytic phases, or in chipmunk phases, they look like the alvin in the chipmunk, like squirrels, right? So chipmunk phase is also classical for this patient. More prominent zygoma, more prominent frontal bone, looks like a chipmunk or in hemolytic phases. CBC, microcytic hypochromic anemia, peripheral smear, obviously you'll have MCHC is your microcytic hypochromic anemia, not your mean corpuscular hemoglobin concentration, right? And this will also have the classical right, target cells. Target cells are diagnostic. The other name for target cells is podocytes. So the investigation of choice is same like my sickle cell anemia. It's same HPLC. That's obviously better compared to hemoglobin electrophoresis. Right? For a beta thal major, The best treatment for me is bone marrow transplantation. Till that, we are going to do supportive measures. Repeated blood transfusion is the only way to treat these patients. And whenever you give more and more and more blood transfusion, there's a problem of iron overload. Obviously, you have to also supplement this patient with the iron chelating agents. That's also required by default. Fine. Okay. Understood. Okay, great. So these are a few pointers for a beta thal major, right? So for beta thal minor, I want to answer only one thing. There is a screening test for beta thal minor called Nestroff test. Remember, Nestroff is a screening test which is based on the concept of same osmotic fragility only. So Nestroff stands for naked eye, single tube, red cell osmotic fragility test. It's for beta thal minor, not for major, because major need not be screened. It will be definitely presenting it from 6 months onwards, right? Why should you screen it, right? That's how it is. Fine. Next, let's go to autoimmune hemolytic anemia. So there are two different types of autoimmune hemolytic anemia, the warm and the cold. Just give me a second. Okay, so we have warm as well as the cold autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia, the most common thing. So you'll have secondary to drugs, secondary to any other inflammatory autoimmune condition, secondary to SLE, secondary to drugs, secondary to CLL. CLL is common for both warm and cold. It can happen with both warm and cold, and this is not very common. And there's one more common trigger for the cold, which is mycoplasma pneumonia. This is important. Post-infection, post-lung infection, when you have anemia, think of a cold autoimmune hemolytic anemia, right? So here it's most common, so it's IgG. Most common is it's not that common as IgM. This is targeted against your Rh antigen. It's an autoimmune disease, right? So these patients will have IgG antibody target against the Rh antigen. This patient will have IgM antibody targeted against a minor blood group antigen called an I antigen. Okay, so both, whatever it is, it's type 2 hypersensitive reaction. This type 2 hypersensitive reaction, whatever may be the RBC here, the IgG or an IgM, IgM always will act along with complements. IgG can act on its own. So this, when it goes via spleen, they'll get caught, and mostly they'll have extravascular hemolysis. Both commonly I'm writing, right? Theoretically, since IgG is a bit more powerful, they are stronger, this can also cause intravascular hemolysis, but it's not clinically significant. That's why I said theoretically it can cause intravascular hemolysis, but the common pathogen is both of them will cause extravascular hemolysis only, right? In both peripheral smear, one common finding is spherocytes. Like I said, this is the most common cause of spherocytosis, right? And obviously the investigation choice for both is 𝐒𝐿's test. You do 𝐒𝐿's test, you can easily pick it up. One important finding for cold autoimmune hemolytic anemia is they will have agglutinated RBCs. This is very classical. This also gives a very important clinical feature of this patient, right? You can see RBCs like this, agglutinated. These are all spherocytes, normal spherocytes, right? This agglutinated RBC is because of IgM, because IgM is pentameric, so it can hold more RBCs together. Imagine this clump of RBC going through a capillary or an arteriole. Can they block? Yes, they can. So this can cause a classical feature of Raynaud's phenomenon. Okay, especially in the colder part of the body where the complement activation everything becomes a little bit more, the patients can end up in having a Raynaud's phenomenon in this patient, right? That's classical for a cold autoimmune hemolytic anemia. Fine. So this is more than enough. Whatever is being asked till now with respect to autoimmune hemolytic anemia, you have the content here. Quick revision, right? That's our goal here. Right. Let's go to IDA. I'm not going to talk about the etiology of IDA. You know the pathogenesis, you know how to diagnose, right? That's undoubtedly the most common anemia which anyone in the world is going to encounter, right? The most confusing thing about IDA is the iron profile. These are the 4 main components of iron profile, and I'm going to give an easy hack to remember that, right? Imagine serum iron and transferrin saturation is directly proportional. Okay, they're directly proportional. In other words, whenever serum iron increases, transferrin saturation also increases. Whenever serum iron reduces, transferrin saturation also reduces, right? Ferritin is the stores. And TABs, let's assume that it's affinity to bind iron. It's not exactly, but I'm using that for ease of understanding. Whenever the stores are less, affinity will be more. Let's assume you're not eaten for 1 day. Will you be very, very hungry? Will be. Just now you had food. Will you be very hungry? You won't have the affinity, right? So these both are inversely proportional. Whenever iron stores are reduced, affinity of TABC will be high. Whenever iron stores are more, affinity of TABC will definitely be more, right? That's how the understanding goes, right? If you remember this directly inversely proportional, it's very simple to extrapolate for any disease for that matter, right? Let's take iron deficiency anemia. Let's compare a couple of them here, right? Less iron, not rocket science, reduced. What will happen to ferritin? That's the most sensitive test, right? There's the most sensitive test for an iron deficiency anemia. Stores has to be reduced, right? Reduced, so TABC elevated. No doubt at all. Let's take anemia of chronic disease. Okay, so when I take anemia of chronic disease, chronic inflammatory state, you will definitely have extremely high ferritin because ferritin is an acute phase reactant. Please start from that. Because ferritin is an acute phase reactant, which I'm sure everyone knows here, it will be elevated. So what will happen to TABC? By default will be reduced. I'm having more stores. Iron is stored. So what will happen to serum iron? Obviously it will become less, not available. So what will happen to your saturation? It will obviously become less, right? So it will obviously become less. That's the easiest concept I can give for your iron profile. Let's look for hemochromatosis. So hemochromatosis, simple. Serum iron is elevated, T-sat is elevated, ferritin is elevated, because obviously stores will be elevated, so obviously your TABC will be reduced, right? Though the last two is not required, this is more than enough, right? I'll give you a hint. This might be useful for your real life in future. Whenever you see a patient with transferrin saturation of more than 45, okay, that's the golden number that you have to think about hemochromatosis. So saturation cannot become more than 45. That's also kind of a screening test in the family of patients suffering from hemochromatosis, fine? This is golden rule. Don't forget that. Directly, inversely, whatever it may come, you will definitely handle that problem, right? Okay, now just a few images, right? Classical images, just 1 or 2 points regarding the images, right? I have 2 sheets of images and all of them are important for us, right? Spotter, hypersegmentation. Hypersegmentation, think of megaloblastic anemia. Megaloblastic anemia can be due to B12. History will be vegan. Can be due to folate. History will be patients with no fruits or vegetables. That's classical for folate deficiency, classical vegan for vegan deficiency, right? More than 5 lobes, more than 6 lobes, diagnostic of an hypersegmented neutrophils, classical diagnostic finding, right? A bone marrow with empty fat-filled spaces, which means it's not functioning properly. You think of an aplastic anemia. Perfect. What will happen to bone marrow aspirate finding? Dry tap. You won't have anything, will be a dry tap. Again a spot, again a classical finding, aplastic anemia, right? So when you have an RBC, which is very, very irregular, right? It's a very irregular RBC and the irregularities are very blunt. It's not very, very sharp. I call them as an acanthocyte. One question which has been repeatedly asked is, you have a condition called an A-beta lipoproteinemia, where you have acanthocytes with malabsorption or a digestive problem. Because this patient cannot absorb beta lipoprotein, so I have this finding. At the same time, this can also be seen in patients with very severe liver failure. Because liver failure also, the lipoprotein cannot be used properly, so you end up in same and the same problem, irregular spikes, acanthocytes, or they have one more name for this. These are also called as burst cells, right? It's very high yield slide. Just look at this before the exam, right? This echinocytes looks like a porcupine, sea porcupine. That's called an echinocytes, or we call it burst cell. Very regular blunt spikes. Classical finding of CKD. Uremia and CKD, you can classically see this, right? Okay, this is also a classical finding. Teardrop, yeah, obviously teardrop cells, or your dacrocystorhinitis, right? Dacrocytes, like a teardrop. So you see them in myelofibrosis. Okay, you see them in classical patients, myelofibrosis, right? Now this is the best thing. When you look at this irregularities, can I say it's sharp? They are, right? If they are sharp angulations, sharp spikes of more than or equal to 2. If you have more than or equal to more than 2 sharp spikes, you use the term schistiocytes. Schistiocytes are diagnostic of an fragmentation syndrome. It's been broken, fragmented, like you can see them in case of an MAHA, microangiopathic hemolytic anemia. You can see them in case of your you can see them in case of your heart, the metallic heart valve, which has been asked on one of the PYQs as well, right? Metallic heart valve will definitely have this problem. TTPHS, you'll definitely have this problem. Hemangiomas, you can definitely have this problem, right? So these are sharp spikes, histiocyte, right? Then looking like a beautiful golf ball, right? So first is I'm writing NB for new methylene blue. New methylene blue will have multiple uniform dots. These are multiple uniform inclusions. Think of a golf ball inclusion seen in case of an alpha thalassemia or an HBH variant, HBH disease. See, the most important thing to diagnose inclusion things in RBCs are the stain. Multiple new methylene blue golf ball. Multiple uniform Leishman. If it's multiple uniform Leishman, I think of an basophilic stippling. So basophilic stippling can be seen in multiple conditions. Anemia, MDS, lead poisoning, right? Even lead poisoning, we have a very fine basophilic stippling. You can myelodysplastic drugs, chemotherapy drugs, even in megaloblastic anemia. Wherever there's a problem with nucleus, you will have this, right? Next, Leishman, multiple but not uniform like stippling, right? It's irregular. It's irregular towards a corner, right? So this calls an Pappenheimer body. So Pappenheimer body is diagnostic or seen in case of a sideroblastic anemia. Okay, that's again a spotter because these are nothing but iron things which are seen in sideroblastic anemia. Fine, clear? Fine, great. Okay, let's look at this. New methylene blue, a single inclusion. That's your Heinz body seen in with your G6PD deficiency. Classical findings seen in G6PD deficiency. Fine, absolutely wonderful. Leishman stain, again a single inclusion in Leishman stain. That's your Howell-Jolly body. Howell-Jolly body is seen in any patients where this is splenic problem, whether this spleen is not present, asplenia by birth, or a splenectomy done for any cause, be it a traumatic splenectomy, any cause, this happens here. Fine. And here you have a ring-shaped structure. Mostly the ring can be an 8 shape or a circular ring. We call this an Cabot ring. So Cabot ring is also diagnostic of all the places where you see megaloblastic anemia. There's a possibility, basophilic stippling, there's a possibility of Cabot ring also, like megaloblastic anemia, like drugs like MDS, you can see them, right? So these two slides are very, very important. It includes almost everything which is required for your final fast revision, right? All the concepts in detail, I've discussed them in the regular lectures, live lectures, anywhere. This is just for quick revision. If you're reading for the first time, this is not your source at all. Okay, let's do the same thing for few important leukemias and lymphomas, right? The same template based, few important problems. That's all is required for us to know from this, right? CLL by SLL. CLL is actually coming from a naive B cell. This has come before. There is an excess production of CD5, which kind of increases a tyrosine kinase called as a Bruton's tyrosine kinase, which kind of causes the proliferation, right? History, it'll be an adult with generalized lymphadenopathy. Adult generalized lymphadenopathy, and CBC shows absolute lymphocytosis. Extreme amounts of lymphocytes, criteria wise more than 5,000. But the most important thing is this lymphocyte should be monoclonal, which means they should have the same CD marker. I'm not going to talk about every CD marker here or the IHC marker. I'll talk only one about it, right? So whenever you see a finding called as proliferation center, that's diagnostic of CLL bar SLL in your lymph node and in peripheral vein. You can't forget this, right? There are two classical findings. One is a smudge cell and an infamous finding called as you know that finding, right? Convent girl appearance, right? So convent girl appearance or a smudge cell, that's a classical finding given for a CLL by SLL, right? IHC, like I said, I want you to remember this thing: CD5 positive, CD23 positive for CLL. This is the most important thing which I'm looking for. CD5 positive and CD23 positive is diagnostic of a CLL. And the most important thing is, in case of a mantle cell lymphoma, it might be a little bit of an alteration where cyclin D1 comes positive. That's one thing. In mantle cell lymphoma, CD5 is also again positive, but cyclin D1 becomes positive and 23 kinds of become negative. Fine. Okay. Complication: a CLL can become DLBCL. This complication is called an Richter's transformation or a Richter's syndrome, right? That's a classical finding called Richter's transformation or a Richter's syndrome. Fine. Mantle cell lymphoma origin It's again pre-germinal center origin or the mantle zone origin. Etiopathogenesis class translocation 11, 14. I remember like this, it's mantle 11. Everything will have 14 translocation common, right? This will have it, right? History, this is a classical history, right? You can have lymphoma, it is also called as lymphomatoid polyposis. A lymphoma presenting as intestinal polyposis is diagnostic of mantle cell lymphoma. Lymphomatoid polyposis, CBC peripheral not much. You'll have an expanded mantle zone. That's a first finding. In case of IHC, I'm going to look for only one guy, cyclin D1. If cyclin D1 is positive, obviously mantle cell lymphoma. In case of cyclin D1 negative patients, you'll have SOX11 positive. Okay, that's it was asked once in the AIIMS exam, just to complete for namesake. Complication, this can become or go into the bone marrow and can go into the peripheral smear. That's one of the complication. We have something called a blastoid mantle cell lymphoma, which also has a very worse prognosis. Fine. Follicular lymphoma. This is purely of germinal center origin. Follicular lymphoma will have translocation 14, 18. So in chromosome 18, you have BCL2. In the chromosome 11, in case of mantle, we had cyclin D1. That's why it is very important. So IHC, BCL2 positive lymphomas are follicular. That's all. History, it's a very low-grade lymphoma. So the problem with low-grade lymphomas, you'll have history for years. When a question says that lymphadenopathy for 5-6 years, or when a patient says that, doctor, I don't know from what time it's there, it's been always been there. I think of this follicular lymphoma, right? CBC peripheral not much. Lymph node will have multiple abundant follicles. They have lots and lots of increased centrocytes. Okay, that's how it is. Fine. Okay, so complication here, follicular lymphoma can have 2/3 of the patient can have bone marrow metastasis in follicular lymphoma, and this bone marrow metastasis will be paratrabecular involvement. That's also classical finding for a follicular lymphoma patient. Fine. Okay. Okay. This is not actually follicular. I'm sure you must have looked at this finding and jumped to the answer. That's your Sari scale, Burkitt's, right? The most important clue in Burkitt's is children. This is the only non-Hodgkin's lymphoma which happens in a child. Rest everything happens in adult, right? Burkitt is also from germinal center. Translocations 14, 18. Sorry, translocation 8, 14. Burk 8, right? I want you to remember as Burk 8 lymphoma, or translocation 2, 8, or translocation 8, 22. The classical findings in Burkitt's. History, you guys know. Whenever you think of Burkitt, African child, jaw swelling. That's a classical finding. I'm not writing that here. In case of a bone marrow aspirate, you might see a blast like this. It's called a Burkitt's blast. So Burkitt's blast might have vacuolations in cytoplasm, and the lymph node, you know, the classical or the famous starry sky appearance. That's diagnostic of a Burkitt's lymphoma. IHC, only one thing which you want to look for is CMYC positivity. And Ki67 is the only place where you can have 100% Ki67. Every cell in Burkitt's is dividing. CMYC is there in your 8th chromosome. That's why it's very, very important for me. Complication, patients of Burkitt's can have one of the important thing, be due to treatment or not treatment. Tumor lysis syndrome is a problem with Burkitt's lymphoma because extremely high proliferation, you might have all the tumor cells undergoing lysis, which can end up in a problem. Fine. Okay. Now few spotters with respect to the WBC chapter. Hairy cell leukemia, right? Perfect. Don't forget BRAF mutation, annexin 1, that's annexin A1 or annexin 1 positivity, and TRAP positivity. Hairy cell leukemia in a bone marrow biopsy will have your kind of an dry tap because of the myelofibrosis, and they do have your classical fried egg appearance in bone marrow biopsy, not an aspirate, right? This is an cerebriform nucleus. This kind of might have been covered in dermatology also, which is seen in Sézary syndrome and erythrodermic stage of mycosis fungoides, which you have your the cerebriform appearance. You can't forget this, right? It's a classical RS cell. Classical RS cell, every classical RS cell will be CD15 positive, 30 positive, and PAX5 will be weak. If it's an NLPHL, which is a non-classical Hodgkin's lymphoma, which will be CD20 positive, 45 positive, and PAX5 will be strong. So this is NLPHL, a non-classical Hodgkin's lymphoma, where you see the popcorn cells as well, right? Popcorn cell is diagnostic of an NLPHL, and you see these classical markers in NLPHL as well, right? Hey Priyanka, good evening. So this finding is an embryo-shaped cell. Priyanka, can you say where do you see embryo-shaped cell or an hallmark cell? We have a condition called as an ALCL, anaplastic large cell lymphoma. An anaplastic large cell lymphoma, one of the important IHC is your ALK. It will be ALK1 positive or ALK positive. This is a classical finding of an anaplastic large cell lymphoma where you have a kind of an embryo-like or an hallmark cell here. Fine. Okay, great. Now what's this? What's this? That's a flower-shaped cell, right? So flower-shaped cell is diagnostic of an adult T-cell leukemia lymphoma. Remember, the virus is important, HTLV1, very aggressive course, and this patient, this is also called as a clover leaf shaped cell or a flower shaped thing, which is also classical finding of an adult T-cell leukemia lymphoma, right? Okay, again, these are few pointers with respect to WBC, right? So if you join late, so I'm just covering quickly what are the important points in RBC, WBC, and let's quickly move towards systemic pathology. So what I'm going to do in systemic pathology is same thing, same routine. We'll have a template. We've done the same template for RBC. We've done the same template for WBC. We'll do the same template for systemic pathology. Few important findings here and there required. Fine. So in vasculitis, type of vasculitis, little bit about the etiopathogenesis, clinical features, and one or two salient microscopic finding. Right. Giant cell vasculitis. First thing, more than 50 years. Never forget this. It cannot happen in a young person. It's nothing but a large vessel vasculitis predominantly, and the patient is going to have a chronic inflammation. Any patient with chronic inflammation, what will be the microscopy? Giant cells and granuloma, right? Obviously, you have giant cells and granuloma. TDHF, tissue destruction, healing by fibrosis. So whenever there's chronic inflammation, there will be tissue destruction. That's been seen here. There's actually a stain called an VVG stain, which is a silver stain, which highlight an elastic tissue stain, which is highlighting the internal elastic lamina. Broken internal elastic lamina is a classical finding for an your giant cell arthritis can also be in Takayasu or your temporal arthritis. Fine. The clinical features here, the common finding is your temporal headache. Okay. The most specific finding in case of temporal arthritis is your jaw claudication. Jaw claudication is one of the most specific finding for a temporal arthritis. And microscopy, like you saw, you can see multiple microscopic findings, the granulomas, the giant cells, and the most important, broken IEL, right? Broken internal elastic lamina is a pathognomonic finding. Whenever you say pathognomonic, if I see this, I do think of an internal elastic lamina being broken. Perfect, Priyanka, right? So the same thing will be seen in Takayasu also, because Takayasu is also chronic. Takayasu also will have the giant cells, Takayasu also will have the granuloma, and Takayasu also will have broken IEL. But the most important thing in Takayasu is less than 50 years. Symptoms might be the same, right? Less than 50 years is diagnostic of a Takayasu arthritis. Type, it's also large vessel vasculitis. There's also the same chronic inflammation. There's only one difference. The most common artery. What's the most common artery involved in Takayasu? It's nothing but your subclavian artery, right? So you have subclavian artery involved. That's a classical finding of Takayasu because of the subclavian stenosis, like you can see in this radiological image here, right? It's been stenosed. There's no dye going out of it, right? Subclavian stenosis, you will have weakness and fatigue in the limb of the entire upper limb, along with a very feeble pulse. Okay, you'll have a pulseless disease. So pulseless disease and a weakness of feeble pulse is diagnostic of an Takayasu arthritis. Microscopy is same as giant cell arthritis or same as temporal arthritis. So the only thing which can differentiate for us is the age, because both of them microscopy will have giant cells, granuloma, broken internal elastic lamina. The history might differ by default, and age also is the most important thing to differentiate these both. Fine. Okay. PAN. PAN is a type of medium vessel vasculitis. PAN is due to chronic hepatitis B infection. Because of chronic hepatitis B, whenever there's an active state which kind of spills over to the vessels or the blood, when it spills over to the blood, it will deposit in the blood and cause vasculitis. PAN will be transmural. And the most important finding of PAN is your temporally dissimilar lesions. This came once in an exam, the same words, temporally dissimilar. Right? What do you mean by temporally dissimilar lesions? Is in the same time, in a pan, you will see both necrosis at the same time. That's very unlikely, right? At the same time, you will see the necrosis, fibrinonecrosis by default, and also healing tissue, and also a scar. Which means ideally, all these three findings should be seen after a week. I cannot see scar and necrosis in the same time. But in pan, you will see that because it's chronicity of HBV, it can come again and again and again. That's classical, right? Pan will spare the lung parenchyma. That's one classical finding of pan. It spares lung parenchyma. It will destroy your kidney by default. Pan will not have glomerulonephritis and no lung parenchyma. There will be no, I'm writing GN for glomerulonephritis, right? This is very classical of pan. And it's not a difficult thing to remember. Pan is a medium vessel vasculitis. It will not affect the small vessels. Glomerulus is a capillary. Lung has capillaries. So lung parenchyma will not be affected. Glomerulus will not be affected, right? And the marker of pan is same as the etiology. See, when you want to identify marker or diagnostic point, go back to the etiology. It will be positive for HPSAG. It has to be positive for HPSAG by default, fine? That's with respect to pan, okay? Clear? I wanted to complete it faster. I'm going a little bit faster because this, I want you to see this video couple of hours, 1.5 hours, 2 hours, just the day before the exam. So it's sorted for you. Just put on the headphones and quickly revise whatever is required, right? Vaginous is the smallest vasculitis. Vaginous is predominantly C and K. That's a pathogenesis. Your anti-neutrophilic cytoplasmic antibody, and also to some extent P and K, right? C and K is your PR3 and K, that's a new name, and P and K is the MPO and K, that's a new name here. Clinical features: bilateral lung involvement is diagnostic of vaginous. Close to 100% of the patients will have lung involvement, and you'll have crescentic glomerulonephritis in the glomerulus. Microscopy, it's granulomatosis, right? You will see granuloma, you will see giant cells and everything. Marker, like I said, you go for your etiology. C and K is the positivity here. That's how vaginous is. P and K will also be positive. For both options present, I'll go for both. Otherwise, I will prefer C and K or an PR3 and K with more than your P and K or your MPO and K, right? Microscopic polyangiitis and your Schuch-Strauss syndrome. Next two are P and K mediated. This is also small vessel vasculitis. This is again P and K mediated pathogenesis. Okay. This generally present as skin. It's a microscopic polyangiitis. Mostly this, you must have read this in dermatology course as Sweet syndrome. Sweet syndrome is a type of microscopic polyangiitis, right? So if you look at this is a neutrophil, right? You can see a tiny neutrophil here. It's a neutrophil here. It's a neutrophil here. You see neutrophils, which means an acute vasculitis. Sweet syndrome is neutrophilic dermatosis. And there are broken neutrophils. These are cytoplasmic nuclear debris of neutrophils, right? That's why it has one more name, leukocytoclastic. Clastic is breaking, leukocytes are WBs, right? Broken. Sweet syndrome, or it could be post-infectious. You might have a history of streptococcal sore throat or something. Post that you have vasculitis, think of Sweet syndrome. Microscopy, again, you will have neutrophils. That's a classical finding. Will this have granuloma, Priyanka? Since it's an acute vasculitis, there will be no granuloma, right? Because an acute vasculitis will not have granuloma. I'll have neutrophils, broken neutrophils. That's named leukocytoclastic vasculitis. This also is P and K positive or your MPO and K positive, right? Schuch-Strauss syndrome, the other name is vasculitis with eosinophilia. So which means this is something to relate with allergy, right? There's also a small type vasculitis, and this patients will have secondary to asthma. Secondary to asthma, secondary to allergy, it's your Schuch-Strauss syndrome, right? All these here are your eosinophils. You see lots and lots of eosinophils here. That's diagnostic here. There's one drug which causes Schuch-Strauss syndrome, which recently FDA also has told that it is involved with patients with, it is also caused neuropsychiatric manifestations in children. That's your montelukast. Okay. Montelukast is one of the drugs which can cause Schuch-Strauss syndrome and recently implicated by FDA for neuropsychiatric problems, right? Clinical features similar to your microscopic polyangiitis, but it's a little bit of a chronic thing because asthma is chronic. The patient might have an ILD like symptom with respect to lungs. And with respect to kidney, yes, the patient will have glomerulonephritis, might go a little bit towards the focal segmental glomerulosclerosis, right? Microscopy is the eosinophils, which gives away the diagnosis. And since asthma is chronic, this patient might have granuloma here. Granuloma will be present, and this also patient also P and COP positive by default. Fine. So these are few things with respect to your giant cell arteritis or the vasculitis, right? Just a few words about the postmortem findings in an MI, because it's a very important topic which keeps coming. Postmortem findings on MI, right? 12 to half an hour to 4 hours. That's 0 to half an hour. You will see no microscopic finding. 0 to half an hour, the entire light microscopy will be completely normal. Light microscopy, electron microscopy can still have changes. Half an hour to 4 hours, the first change which causes waviness of fiber. I can see the fiber becomes a little bit wavy, right? That's a first light microscopic change. 4 hours to 24 hours, you will see only necrosis. So it will be completely pink tissue, not even neutrophils. Till a day, it will be only necrosis. 1 to 3 days, you will see both necrosis and neutrophils. If you look at Robin's table, it will be written that first day neutrophils start coming, and the third day neutrophils will start disappearing. But that's a bit difficult, right? So here, a good amount of necrosis, and obviously in between you have neutrophils. So I can approximately say it's somewhere around 1 to 3 days, right? 4 to 7 days, the healing start. So what will have? Macrophages, and the macrophages will be clear. Macrophages are clear cells, right? That's a 4 to 7 day. After macrophage comes the healing slowly becomes a bit more consolidated. 7 to 10 days, you'll have granulation tissue. The easiest way to identify granulation tissue is vessels. You see lots of blood vessels in microscopy. That's RBCs. Look for RBCs in circles. Blood vessels, granulation tissue, right? Last but not least, anything beyond 10 to 14 days, even it may be a year, 2 years, 3 years, you'll see only one thing, which is your collagen fibrosis, right? That's what you'll be seeing in case of the terminal event of collagen fibrosis, right? So these have been repeatedly asked postmortem findings in MI. I don't know, they have an affinity to asking about Ashoff bodies also. I have not included Ashoff bodies here because I am 100% sure that you know Ashoff bodies, right? It's something which you have been reading from second year of MBBS, repeated in your final year, repeated in every PYQ session. I'm not going to repeat it, right? Reperfusion injury, this came in recent NEET exam. The microscopic finding for reperfusion injuries, your contraction or eosinophilic contraction bands. So you can see this extremely thick fibers, right? That's an eosinophilic contraction bands. That's diagnostic of your reperfusion injury, and said that most common reason for reperfusion injury is reactive oxygen species induced damage. If you read medicine, they must have told that you need to reperfuse the stroke within this critical time. If I'm going to reperfuse beyond the critical time, this is what will happen. Fine? Fine? Perfect. Okay. Next. The 4 vegetations. I'm sure you must have definitely seen that, right? You have must have seen multiple times. Extremely along the lines of closure, right? It's rheumatic heart disease. One thing which I don't want you to forget here is it's a sterile vegetation. It's not infective. Little bit kind of destroying. If it destroys the valve, if it's infective, there's only one vegetation which can also have an emboli, infective endocarditis. Little bit bigger size, along the lines of closure, again sterile. We call it an NBTE, non-bacterial thrombotic endocarditis, classical. On both sides of the valve surface, right? On both the sides, you have a term which is your Libman sacs. And I'm 100% sure you know that where you see Libman sacs. You see Libman sacs in the case of perfect SLA, right? That's where you see Libman sacs endocarditis. Classical findings seen in case of an systemic lupus erythematosus, right? Perfect. Few words about your emphysema, because the gross finding of emphysema is asked one of the PYQs, one of the NEET exams. Centriasna is the most common subtype. This is a bit rare. Centriasna more common because it's more associated with tobacco smoking. Obviously, that's the common cause, and this is more commonly seen. Like pan-asthma is more commonly seen with alpha-1 antitrypsin deficiency patient, so that makes it rare. It involves predominantly upper lobes. For some unknown reason, pan-asthma involves predominantly lower lobes of lung, right? So I have third type of emphysema, like you can see in this image here. That's an bullous emphysema. You can see the bulla here, the tiny one is projecting outside, right? Or you can call it a distal acinar emphysema. So bullous emphysema or distal acinar emphysema might end up in the introductory scene of a good doctor. The patient might have an complete sudden respiratory onset, absent breath zones, put an intercostal tube drainage. That's the only way to save this patient. That's what you're going to see in this patient. Classical finding for a bullous emphysema patient. So how do you differentiate centri and panacinar in gross? Because that's what came in an exam once. In gross, very simple. When you see only emphysematous lung, it's panacinar, complete. When you see both normal and emphysematous lung, it's centriacinar. Because centriacinar have both normal and emphysematous. Panacinar will have only emphysematous lung. That's what happens here. Fine. Okay, great. Okay. Emphysematous lung, normal lung, right? Normal lung. Emphysematous, centriacinar. Only dilated lung, only dilated alveolar spaces, no normal alveolar spaces. You go with an panacinar emphysema. Fine. Perfect, right? The last chapter, right? We'll just quickly wind up in the next 10 minutes, right? I'm rushing up for the only reason. I assume that you've already done the entire things. But if you want conceptual understanding, please go back to your first recorded lectures. If you're second year, go back to your live lectures. And that's how we're going to learn a little bit more confidently. Fine. Okay. So this is a normal glomerulus. This also came once in an exam. When you see a very thick capillary, only thick capillary, I think of two diseases, MGN and anti-GBM glomerulonephritis. That's your Goodpasture syndrome. Only thick glomeruli, membranous glomerulopathy or a Goodpasture syndrome. When you see lots of cells inside the capillary, that's your endocapillary hypercellularity. Look at these. These are nothing but classical neutrophils, right? See the neutrophils. They are only neutrophils here, right? So you see lots of neutrophils inside the capillary. I think of an PSGN or PIGN, right? On the other hand, see this is a normal mesangium. Look at this as an extremely high mesangium. So when the mesangium is very, very thick, I think of an IgA nephropathy, or I can also think of an MPGN2. Because here I don't have cellular proliferation inside the capillary, right? I think of MPGN2. And the only way to differentiate of these two, like there are two differential diagnoses here, right? So how do I differentiate? You go for immunofluorescence, that's all, right? This is light microscopy based. Immunofluorescence, again, this is normal. Entirely dark green in color. Immunofluorescence, green color is positive. Green color is due to a dichromatin FITC. Fluorescent isothiocyanate, because you have learnt about DAP stain, which came in an exam for immunohistochemistry. For an immunofluorescence, FITC is the right dye, fluorescent isothiocyanate, right? And if you can look at this, that's linear positivity. Linear positivity is seen only in case of a Goodpasture syndrome. This is granular. Rest everything in our body is granular. Be it PSGN, MPGN, your whatever it is, what MGN, everything is granular positivity, right? And this is mesangial positivity. So both the disease which had mesangial expansion will have mesangial positivity. Then how do I differentiate IgA or MPGN type 2? It's simple. If mesangial positivity is both for IgA and C3, I go for Berger's disease or IgA nephropathy. The mesangial positivity is only for C3. I go for MPGN type 2 or your C3 glomerulonephritis. Fine. It's simple. The thing is not about where it is positive, it's about what it is positive, right? If the IgA is positive, IgA nephropathy, no IgA, only C3 glomerulonephritis, right? That's how we differentiate. And never forget this is a spotter. This has been asked previously once. Just an image of Goodpasture syndrome can be asked, because the only disease which can have linear positivity. Fine. Okay. That's a classical crescent. It's in crescentic glomerulonephritis. A beautiful crescent compassing everything. An electron microscopy of a crescent also has come before. That's a break. You have a break in the basement membrane. That's classical for a Goodpasture syndrome. Sorry, Goodpasture syndrome can also have crescentic glomerulonephritis, right? Or an RPGN. RPGN is put into three types. The first is Goodpasture syndrome, where you have linear positivity. Next, type 2 is granular positivity or an mesangial positivity. Rest every glomerulonephritis comes here. Right? Be it an MPGN, be it an lupus, be it an PSGN, be it an MGN, everything comes here. IgA nephropathy, everything comes here. Type 3 is pauci-immune. positive immune or no positivity for immunofluorescence. All these are immunofluorescence based. You think of an vaginal, this is not actually a primary problem of the kidney. It's a problem of the small vessels or your microscopic polyarteritis, right? So this both also can cause RPGN, but it will have no immunofluorescence on kidney because their problem is primary small vessel destruction. That will obviously destroy the glomerulus as well. Fine. Okay. This is the last slide. Classical spotters. Okay. I have put wantedly combination of all these things together because most of them are looking pink in color, right? So if you see a section of the glomerulus completely pink, like a scar tissue, this is FSGS. Focal segmental glomerulosclerosis, right? This is the most common cause of nephrotic syndrome in adults. Children, you know, it's minimal chain disease. And this is the microscopic finding for any CKD. It's sclerosed kidney. Same time, if you have nodules of sclerosis, see here, it is not nodules. Here is nodules. Nodules is your KW lesion, Clemmenstein-Wilson lesion, nodular glomerulosclerosis. You see them in a specific finding for diabetes. On the same pink you see in a wall of a vessel. It's not in the glomerulus. You see in the wall of an arteriole, right? This is an arteriole, and the arteriole is seeing the wall. This is your benign hypertension or your hyaline arteriolosclerosis, right? It's not the glomerulus, but it's in the arteriole. But the same arteriole is becoming like an onion skin. I am sure you know that. Onion skin appearance or the gross appearance of your flea-bitten kidney, you won't forget that. That's your hyperplastic arteriosclerosis, right? This is seen case of a malignant hypertension, right? So these are 4 things. Most of them are pinkish in color. You might end up sometimes in an error. You might miss it. You might write it wrongly. So these are the findings where you see them in other things, right? So that winds up the most important findings. So if you are struggling with pathology or if you're trying to find it difficult to revise pathology, 2 source videos for you. One is in the PW Meded YouTube channel, the new next channel, where I have had a session on Daskadam. That's for approach. And this is for compilation. Whatever is required, the final 2 hours, 2.5 hours to see, maybe look through these 2 PDFs or these 2 lectures in 1x or 2x or 3x, whatever you possible for you, and complete it, right? All the very best. Hoping to see all of you in the next interview session, and hopefully we will see you as consultants sometime. Hopefully we'll work together sometime as well. Fine. See you guys. Thank you. Thank you for your time.